Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, a new way of thinking about paying for health. Dr. Darshak Sanghavi is a pediatric cardiologist who has developed national programs that take a totally different approach to healthcare finance. He speaks to Dr. Josh Sharfstein about these efforts, both in the past and the future. Let's listen.
Dr. Darshak Sanghavi, thank you so much for joining me today on Public Health on Call to talk about a very interesting idea that you have been a champion of for a number of years now.
Josh, as always, great to talk to you.
So we're talking about the idea of healthcare finance, but not the usual healthcare finance where people get paid for providing a service, but the idea of paying money, and in some cases a lot of money, for the health of a community to improve. Is that a fair way of describing what you've been working on?
Yes. I mean, obviously in healthcare, we get what we pay for. And for so long, we've said, well, why are our outcomes not as good as they should be? I think most people believe it's because we pay for widgets or procedures, and we don't actually pay for the thing we want in the end. So as you said, that's been the animating central idea about what I've been working on.
So what is it that we want in the end?
Well, I think about, Josh, you and I trained together in pediatrics, and I think the things we want are what I think most people think about when they think about health. They want a life that's free of a heart attack or stroke. You want to have a child who actually grows up without the burden of a significant mental illness. You want to have all of these things that are associated with health. Very few people say, what I want is a bypass surgery or I want this particular medication. What they actually want is the outcome. And so our payment, though, has never aligned it. So I think that's sort of the problem we're trying to solve.
So take me through how you've thought about this problem. What are the kinds of solutions you've thought about?
Yeah. So probably the earliest area where I got deeply involved was almost a decade ago when I was fortunate enough to join the Center for Medicare and Medicaid Innovation. And the problem we're trying to solve is how do we prevent heart attack and stroke in America? And the way we had typically done is say, okay, let's control blood pressure for everybody, the quality metrics and value-based care focus there. We did something very different in something called the Million Hearts model, where we said, okay, why don't we think about a whole population? In this case, the Medicare fee-for-service population said, well, what's their actual risk of heart attack and stroke in the next 10 years? And we could calculate that fairly easily using established calculators. And we said, well, what if doctors, rather than saying, well, we want you to use statins or control blood pressure, said, we're just going to let you figure out how you want to lower that risk by whatever means you see fit for your whole panel population. And we actually did a randomized study, and we found that when we paid for that and created an incentive, and it wasn't even that much, that was a 5-year program ran from 2015 to 2020, we actually dramatically lowered the rate of heart attack and stroke, and in fact, even improved mortality. Nationally, if we sort of created that, if we paid for everybody, that would save a number of seniors that could fill the University of Michigan football stadium. So these are big, impactful programs.
I want to follow up with some specific questions to make sure I really understand. So you're working for the federal government, essentially for the Medicare program in their innovation center. And instead of saying to doctors, we're going to pay you a certain amount for each visit, or even we'll pay you a little bit more if the patient has their blood pressure controlled, what you said was, we're going to look at the chance that all of your patients are going to have a heart attack or stroke, which we're calculating based on various risk factors.
Exactly.
Your job is to reduce that. And if you reduce that, only then will you get extra money.
That's exactly right.
And when you did that, you did it in a randomized way. So some doctors had that incentive and some didn't. And the ones that did actually were able not only to lower the risk of a heart attack or stroke, but actually to lower the mortality, the chance of dying of their own patients.
Exactly. That's exactly what we did. And it's actually one of the largest randomized trials of payment for prevention ever done not only the US, but in the world. It involved in total about 3.3 million Medicare beneficiaries and thousands of practices nationally. So we really felt good about the level of evidence we had also created at the time.
Now, let's just pause to say this has not spread widely across the country, maybe as much as we'd want. Why do you think that is?
That's right. Well, so I will say that some pieces of this program have been codified in the Medicare fee schedule very recently around initial risk stratification and so forth. So that there are pieces that have been taken out. But I think fundamentally, we still have a lack of alignment because that's just Medicare, right? It's Medicare fee for service. So what about Medicare Advantage? What about anybody who's over the age of 40 who's at risk of heart attack or stroke? So the issue is we have a highly fragmented purchasing marketplace. And when you have that, it's just really hard to focus on an entire population's health. That was one of the challenges.
And do you think there's also a kind of a cultural challenge within medicine? Like, why would you pay me for this outcome when I can't necessarily directly control that? You should pay me for the things I'm doing.
For sure. One of the things I found is that clinicians in particular, I believe that they have the right intrinsic motivation, or many of them do. You want to do the right thing for your patients. And is the system allowing you to do that right thing? And when your Medicaid churn is 25% per year, or your commercial insurance carriers are changing all the time, and people are moving in and out of your practice, there are significant, not only financial, but also practical barriers for managing that longitudinal risk, particularly for something that's not going to happen for 2, 3, 5, or even 10 years.
So part of the challenge in embracing solutions like this is just the chaos that is the US healthcare system.
Absolutely. But I think one of the things I've come to believe is that you could sort of get lost in that complexity, but in fact, the solutions may be a little easier than we think. And I think that's been where I've been particularly interested, which is not like cursing the darkness, but seeing where can we light candles.
So you worked in another federal agency and you took this idea to a whole new level. Talk to me about that.
I was very proud of this, and this is work that a really great team had put together. So about some time ago, about 2.5 years ago, I joined a new federal agency called ARPA-H, which is the moonshot agency that was founded under the Biden administration has continued to be funded under the Trump administration. The idea here was high risk, high reward work. Most people think about that as, hey, we're going to print organs or we're going to create new gene therapies. We sort of said, well, what if we also thought, how do we radically shift how we pay for care in ways that even Medicare, Medicaid, and insurers can't do? So we did something that, taking that Million Hearts model, and we built a program that we called Heroes. And the idea was, what if we took a whole geography, like the whole state of Alabama, or as you know, the entire city of Baltimore, and said, let's track a specific metric, opioid overdoses, risk of heart attack and stroke, or maternal complications at birth, the horsemen of the apocalypse that were affecting public health. And if we could track and address those, could we do that at an entire community level?
So this is a big innovation. You're at an agency devoted to innovation, and you want to pay essentially a city or a set of counties for actually succeeding in saving lives from overdose, heart attack, birth complications. How do you even go about doing that?
Yeah. So the way we did it was actually, this is one of those things where the steps are easier sometimes than we give people credit for. So the first thing we did was we said, well, we need the data. So we actually built a dashboard for the first time that was as near real time as we can get it, that at the zip code level across the country would track these outcomes. How many women are having major complications? How many overdoses are occurring? And when we first did that, you could see where those pockets were, and we could track that nationally. So the first piece was, could we get the data? And we did. Then the second thing we said was, well, who's willing to take this on? And this is one of the great things about doing public health is that there are organizations that will come together, like areas like Texas, Alabama, Baltimore, parts of Wisconsin. Health clinics, community service organizations, providers, they all came together and said, we're going to take this on. They built entire strategies, and they came together as little entities called health accelerators, said, we'll take this on. We'll invest the money as long as we know somebody's going to buy that outcome in the future. So incredibly, it actually does happen.
And so this Heroes program, You set up the data infrastructure. You ask people to develop a strategy, and then you were going to pay if the strategy succeeded.
Correct. Meaning the federal government wrote what we call an advance purchase agreement. So in other words, we said, look, you do this, we're good for this. We'll buy up to, and we had dedicated about $100 million at the federal government level. The key was we didn't want to just be the only people funding it. So then we also raised about $200 million of non-governmental capital, meaning payers, employers, philanthropy that would sort of pick that up once we started to see results and ideally continue that. The other thing I'll say, just one more thing to say crucially, this has nothing to do with healthcare. It's not through the traditional billing system. So this is not competitive with other value-based care, other organizations. It's completely a separate, just purchasing an outcome from the public health standpoint.
Concept of Heroes was an outcome buyer. The federal government would be an outcome buyer. Could you explain what an outcome buyer is and how that relates to this general idea of paying more for actually better health?
Yeah. So I think traditionally we think about a purchaser like Medicare or private insurer. They are buyers, but what they're buying is not health. They're buying medications. They're buying procedures. They're buying time with a doctor or a therapist or a nurse. We changed that up so that instead of paying for each of those little pieces, we just said, you figure it out. In a sense, it's returning control to the communities themselves and the systems that need to be changed. And so that was the whole idea, was rather than paying a single individual for doing something, we paid an organization and said, we're going to deliver an outcome.
It's a really interesting and different way of thinking about paying for healthcare. And as you said, it's not competitive with paying for procedures. You can still do that, but then you have this extra benefit if actually people are healthier, if they're living the lives they want to live and they're not getting interrupted by unnecessary heart attacks, strokes, overdoses, and other complications. So what happened to the Heroes program?
Yeah. So, it was a challenging time. So we had actually put the program, we had announced it at the JP Morgan conference of roughly 2 years ago. We did an open solicitation, actually recruited about 20 communities. And we were going to impact the lives, I hope positive, about 30 million Americans. And I think, unfortunately, priorities at the administration level changed, and we actually had almost fully contracted all of the entities and raised all the money, and the decision was made to refocus funds in other areas of government, and the program was unfortunately not continued. So it was deeply frustrating because we had gotten so close.
So close.
Yeah.
Do you think that any of those projects might continue with the other outcome buyers that you had recruited?
Yeah, so that's the hope, is that, I'm an optimist and I think these good ideas will find a way. So yes, there's a couple ways this could move forward. The first is some of the participants actually are moving forward anyway because they were able to raise money on the private markets, which is great. We like to think that the federal government could help, but they will proceed. The other thing is that the ideas and the coalitions that have been built will be durable. Perhaps they might even qualify for those rural health transformation funds or potentially state Medicaid. And so even payers will continue that. So I'm optimistic that even though the program won't continue in the Cadillac form, quote unquote, that we had envisioned, I believe that several pockets will continue.
Got it. Well, this is never going to be easy because you're talking about very, very serious reforms of the way health and healthcare are paid, but you have done a tremendous amount over the last decade to introduce a whole new concept into healthcare finance. Dr. Darshak Sanghavi, it's always great to see you, and thank you so much for all of your work.
My pleasure. Thanks for talking.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.